The classification of NETs is very complex, and that's one of the things that I try to explain to the patients. We classify them typically in well-differentiated, moderately differentiated, and poorly differentiated. But on the top of that, we also classify by grade. Grade 1, which are typically patients that have a low mitotic index per high power field, and a Ki-67 in the cells between 0 to 2. Grade 2, when the Ki-67 is between 3 to 20, and grade 3, when the Ki-67 the Ki-67% is more than 20%. And that will be important because that will define how you're treating your patients. Patients that have grade 1 certainly have a very different way of being treated compared to patients that have a grade 3 or a high grade tumor. So it's very important from the beginning to have a very good communication with your pathologist, being able to identify exactly what type of or subtype of neuroendocrine tumor we are dealing with here, because that will really impact your treatment decisions. In terms of primary site, we also try to identify from the embryological origin foregut, midgut, and hindgut. And patients that have a midgut tumor or a small bowel tumor, they typically behave in one way. Patients that are from the foregut or for the pancreas, they behave a little bit different, and the options will be different. There are a few more options for patients with pancreatic neuroendocrine tumors than we have for small bowel neuroendocrine tumors. So for all of that, it's also very important to, when you're thinking about the patient and how you're going to treat it, to take into account where's your primary tumor.
Neuroendocrine tumors are extremely diverse. It's not really one cancer. It's a family of cancers, and about as heterogeneous a group of cancers as we see, because it ranges from the very slowest growing tumors to the fastest growing. The small cell histology technically is a form of neuroendocrine carcinoma. So there's a lot of different ways of distinguishing prognostic groups. We look at differentiation in grade referring to the proliferative activity of the tumors, mitotic rate and Ki-67. We look at the primary site. Each primary site has its own distinct biology we're learning, which explains why the clinical behavior is so different. We look at whether tumors express somatostatin receptors or not, whether they're hormonally functioning or not, and all these things influence both treatment and prognosis. So, for example, the poorly differentiated neuroendocrine carcinomas are treated with platinum-based chemotherapy, which is completely different from the pattern for most well-differentiated neuroendocrine tumors, which are treated initially with somatostatin analogs. It gets very complicated, but the bottom line is it's a very diverse group of tumors.
There are a fairly significant number of our patients that come to us with their disease almost incidentally detected. Perhaps they had brief abdominal pain and ended up in the emergency department, underwent some imaging that found several small liver metastases and perhaps a primary tumor in their abdomen somewhere. These patients are otherwise asymptomatic. They're quite concerned, obviously, about the diagnosis of a metastatic cancer. Often the biopsy will show a very well-differentiated neuroendocrine tumor without a very high mitotic index, or Ki-67. And we know that these patients often can have stable disease with very, very slow growth for long periods of time to come. Yet we also know that the disease is not curable. So the question is, if we're hopeful that somebody may live 5, 10, 15 years with their disease, do we need to aggressively treat them up front? So I think many of these patients are candidates for observation without therapy. If we look at a number of the clinical trials in the recent decade that randomize patients to an active therapy, such as a somatostatin receptor antagonist, everolimus, sunitinib, they were always compared to a group that received placebo. The placebo group generally got treatment later on, and there isn't one of these trials that shows even a hint of a long-term overall survival advantage. And this would suggest that patients can receive the benefit from these same therapies further down the road in the course of their disease and be spared the costs, the toxicities, the hassle of receiving therapy, as long as they're being followed closely in an expert center. So I think there actually are many patients where initial observation is a quite reasonable treatment strategy.